Psoriasis, um, it arises from a Greek word. It means itchy condition, or sora means itch and cis means condition. So it's considered to be a papillosquamous disorder of the skin. So what is papillosquamous disorder? Papule means any kind of raised elevations that is less than 1 centimeter in our body. And squamous means the upper layer of our epidermis, which usually sheds off. The squamous cells are present in the upper layer of epidermis. So here the papules, the presence of papules and the scaly squamous layer is the characteristic of the disease. So that's why it's called as a papillosquamous disorder of the skin. Other conditions like lichen planus, seborrheic dermatitis, all these are other papillosquamous disorders. And it is a non-contagious. That means it does not spread from one person to another on touch. An immune mediated inflammatory skin disease. That means it is having an autoimmune cause. It means our own immune system is acting upon against our body, and here more specifically the T cells are getting an abnormal response, which leads to an improper or immature proliferation or differentiation of the epidermal cells. That means our epidermal cells, it is produced 6 to 9 times faster than the normal. It is produced and it is shed off faster in a faster rate. So before it gets mature, it is shed off. So the skin cells keeps piling up due to increased production, and it scales off faster, leading to these characteristic features of eruptions and scales in the skin. Characterized by a well circumscribed. And how the lesions looks like, it is well circumscribed, means well defined erythematous, which redness will be present. Then it's dry, silver colored, and it is centrally attached. The scale will be centrally attached to the skin, scaling plates. It's usually chronic condition, goes for a long time and relapses. Each relapse means it subsides in between and again relapse. It's the character of psoriasis. Now we will go through with some relevant anatomical points regarding the epidermis. You can see the layers of epidermis in this picture. The most lower part is the stratum basilae, which is attached to the dermis, and above that it is a stratum spinosum, and then comes the granulosal layer, then stratum lucidum and stratum corneum. And above that, you can see the dead cells flaking off at the skin surface. That's the area where the dead cells flakes off normally. These skin cells or keratinocytes, it's also called as keratinocytes. It's mentioned as keratinocytes. These keratinocytes undergoes two types of changes while it gets mature. That is proliferation and differentiation. Proliferation means an increase in number, whereas differentiation is the change or else any specialized character it acquires while it grows up. That is differentiation. The cell while growing up, it acquires certain specialized features. That is differentiation. So the cell, usually keratinocyte, usually proliferate and differentiate in normal course of maturation. So usually the basal keratinocytes, it proliferates and migrate upwards. From the basal area, it migrates upwards and differentiate into the next layer, stratospinosum and then granulosum and lucidum and corneum. Sorry, so corneum, and in corneal stage it loses its nucleus and later it sheds off. So all this action is called as differentiation, proliferation and differentiation. There is increase in number as well as there is changes in its structure while getting matured. So normal cycle of this proliferation and differentiation, it is different in different parts of skin, in different parts of body, but usually it is 40 to 70 days. Now we will just see the pathophysiology of psoriasis in a nutshell. The complete process is even now it's not completely understood, but psoriasis is an autoimmune condition and a series of happenings are occurring, which I'll explain in short. So usually whenever a bacteria enters our body through a cut in the epidermis, say through a cut, when an injury occurs, There's a cut, and the bacteria toxin enters the body, and it's usually it's taken up by the dendritic cells present in the epidermis, and these cells have a substance called as MHC in the cell wall. MHC, or the major histocompatibility complex. Uh, it is actually a group of genes or protein markers that helps the antibodies to distinguish between a normal cell and an infected cell. Okay, so how I'll explain. The dendritic cells, these receives the bacterial toxin and it processes the antigen material, maybe by phagocytosis or something. It engulfs and it processes, and it is present into the MHC. It gives that viral antigen or bacterial antigen to the MHC, which is situated in the cell wall. Okay, so now the cell is carrying the viral antigen in its MHC and moving. Okay, and whenever an antibody comes, it sees the MHC with the viral or bacterial antigen in it, and it realizes that okay, this is an infected cell. So that is the method how an MHC helps in distinguishing between a normal cell and an infected cell. So here the antigen is present into the MHC, and now the immune system gets activated, and a T cell, and this viral antigen or bacterial antigen is given to a T cell. A T cell receives this antigen, and usually as a result of this activation of T cells or helper T cells, usually interleukins are released. Inflammatory mediators or interleukins are released, and after a series of happenings, cytotoxic cells are released, and then antibodies against the viral or bacterial antigen is released in our body. This is the usual method. What happens in psoriasis is usually when this viral antigen or bacterial antigen is being taken by received by the MHC, and a T cell receives it, there is an abnormal response in T cell due to an autoimmune reason. It's an abnormal response in T cell, T lymphocyte, which leads to an excess secretion of inflammatory interleukins. So these interleukins are excess release. So our inflammatory process is increased in an increased rate. And at the same time, what happens is that the keratinocytes or the skin cells present in the area, as a result of these pathological changes, it undergoes hyperproliferation, because hyperproliferation means increasing in number. Hyper means it starts increasing in too much numbers. The skin cells starts increasing in too much numbers, and differentiation is improper. Also, the process of getting mature is also slowed down. Okay, means the process gets faster now. So before getting mature itself, the skin cells usually shed off. It increases in number and it piles up one above the other, and it is presented in the squamous layer as a scale. So that is an improper differentiation and hyperproliferation which is happening as a result of this abnormal autoimmune response happening. According to age, psoriasis is usually divided into type 1 psoriasis and type 2 psoriasis. Type 1 psoriasis is of early onset, means 75% of the person having psoriasis, it's of type 1 psoriasis. Means females it occur in an early age of 16 years, and males usually 22 years. And it is predominantly involved with the presence of HLA, CW6, DR7, B27. What is HLA? I explained. HLA is nothing but the major histocompatibility complex in human beings. In human beings, it is present. MHC is presented as HLA, and HLA of CW6, HLA, etc. are the HLA which is involved in formation of psoriasis. So it's helpful in the diagnostic aspect, the presence of HLA, CW6, etc. And type 2 psoriasis, it is late onset, means after 40s or 50 age. So 25% of the total cases, it is type 2 psoriasis. It's seen after 45 to 60 or 50 to 60 years, and it predominantly involved HLA-CW2 only. So incidence is equal incidence in males and females. It is almost seen equally in males and females, and average age of onset is 23 to 37. Now we will just see the causes or triggers of psoriasis. The first major cause is genetic itself. The genetic relation is that if one parent is affected, 16% chances are there for the offspring to get a psoriasis. If two parents, both father and mother, affected, it is 50% of chance that the offspring gets psoriasis. Whether instead of father, if psoriasis is present in father, the more the chances than psoriasis in mother for the offspring to acquire it. In non-psoriatic parents, usually have a child with psoriasis. If they have a child with psoriasis, the 10% chances of the next child having psoriasis. And also in case of monozygotic twins, it is 70% chances to attain psoriasis, and 20% in dizygotic. Monozygotic means identical from the single egg. It's a single egg dividing into two. These are identical twins, and in dizygotic, it's two separate eggs are involved. It is 20% chance of attaining psoriasis. And now we will see the other causes or triggers for psoriasis. Trauma is a major cause. Trauma at scratches or surgical wounds. Scratches or surgical wounds which later can lead to psoriasis. Kopner phenomenon is a phenomenon. I will explain it later in the following slides. Infection with hemolytic streptococci. Streptococcal infection can lead to psoriasis, especially a type of psoriasis called as guttate psoriasis. If tonsillitis is present due to hemolytic streptococci, it can lead to guttate psoriasis. Also, HIV presence is also an increased incidence for psoriasis. Then hormonal reason in pregnancy, it is seen decreased. Psoriasis is seen decrease in pregnancy, and postpartum after delivery it relapses. So hypoparathyroidism, again hypoparathyroidism means the parathyroid hormone is decreased in secretion. It's actually important for the presence of regulation of calcium metabolism in our body. So if the parathyroid hormone is less, it leads to hypocalcemia in such persons. It is seen that psoriasis is increased in hypoparathyroidism. Also, sunlight is another factor which improves psoriasis. It is used in part of treatment of psoriasis. And in some cases, on 10%, exposure to sunlight worsens the condition. Again, certain medications or drugs, like anti-malarial drug, it increases psoriasis, chances of flaring of psoriasis happens. Then beta blockers and calcium channel blockers, which are used to decrease the blood pressure. Usage of these in certain persons is seen, the flaring up of psoriasis is seen. Then usage of lithium in certain medications for use for bipolar disorders. Then terbinafine is an oral antifungal. It can cause psoriasis or it flares psoriasis. And certain lipid lowering drugs used for cholesterol decrease or cholesterol extra. It is also seen having an effect in increase of psoriasis. Again, steroid withdrawal. If the person is on steroid for some other reasons, upon withdrawing it, sometimes there is a flaring up of psoriasis. Then smoking and alcohol, usually it increases psoriasis. Emotion, upset, it also increases the psoriasis, and obesity is also another factor that increases psoriasis. You can see some common clinical manifestations in general symptoms of psoriasis. It will vary according to the types of psoriasis. So initially there will be red spots in the body, followed by dry, swollen and inflamed patches of the skin. It will be usually covered with a silver white flakes that indicates hyper proliferation and differentiation of the keratinocytes. That is early maturation or the immature keratinocytes which are shed off and increased in number. Raised and thick skin. Other symptoms includes pain, itching, burning, sensation, and presence of dandruff, then pus-filled blisters, genital lesions in males, etc. Now we'll see the types of psoriasis. Several types of psoriasis have been mentioned, and I'm here mentioning certain important types. There is plaque psoriasis, guttate psoriasis, inverse psoriasis, pustular psoriasis, erythrodermic psoriasis, then nail psoriasis, and psoriatic arthritis. It's an associated condition. Plaque psoriasis, it's the most common type of psoriasis, also called as psoriasis vulgaris. Usually it appears as a raised, inflamed red skin covered by silvery patches or scale. You can see it in the picture. Silvery patches or scales. The sites are usually the elbows, knees, sacrum, scalp, lower back, hands and feet. Especially the extensor part of the body. The guttate psoriasis, usually it manifests at an early age, so less than 20 years of age. So it is seen as a type 1 psoriasis. The character of the guttate psoriasis is the eruption of small papules. That is small eruptions, raised elevations which is 1 millimeter to 1 centimeter in diameter. And the color is salmon pink. Salmon pink is some orange shade, some pink and orange shade mixed. It relates to the flesh of salmon fish, the color of the flesh of salmon fish. Then shape is it's guttate. Guttate means in Latin it is spots that resembles the drops, water drops. So small drops. It resembles the drops. So arrangement is it is scattered and discrete, separate, scattered and separate, well-defined separate lesions. Distribution is generalized, seen all over the body, especially over the upper trunk and the proximal extremities, usually sparing the palms and soles. It's less on the face, scalp and nails. So it is more in the trunk and proximal extremities. It is seen, it's usually not seen in palms and soles or face and scalp and nails, etc. Again, a streptococcal throat infection is associated with guttate psoriasis. So this is the diagram of guttate psoriasis. You can see that well-defined, discrete, scattered lesions, which are like water drops, especially in the upper trunk. Inverse psoriasis or a flexural psoriasis. It is seen in the flexures or joints of the body, like axilla, etc. So it's localized in major skin folds such as axilla, the inguinal area and inflammatory areas and sweating areas. The scaling is usually minimal or absent. Usually scales are present in psoriasis, but in inverse psoriasis it is minimal or absent. The lesions appear as glossy, smooth and bright red. So it will be on the contrary, it is glossy, smooth and bright red with minimal scales. It's commonly seen in the obese persons. Next is pustular psoriasis. Pustular, it means it has the presence of pus in it, eruptions with pus in it. So two forms are there. It's usually localized and generalized, and localized is the most common type of pustular psoriasis with deep-seated lesions or deep-rooted lesions with multiple small pustules on the palms and soles. So these are the places where the pustular psoriasis is seen, that is palms and soles. Generalized psoriasis is uncommon, it's not common. It has fever associated with and widespread pustules across the body surrounded by the red skin. In the second picture, second diagram, you can see a generalized pustular psoriasis. and you can see the inflamed body surface with its redness marked by the redness. Next is erythrodermic psoriasis. Is having generalized erythema or redness. It's covering the entire skin surface. Usually, it evolves slowly from a chronic plaque psoriasis, and person having chronic plaque psoriasis, and later it evolves or changes into erythrodermic psoriasis, or it may appear as a separate eruptive phenomenon. So it can occur as a continuation of chronic plaque psoriasis or as a separate eruptive phenomenon, usually fever or hypothermia or hyperthermia, along with dehydration is seen in the condition. Nail psoriasis is commonly seen along with psoriatic arthritis. It appears as a pitting. You can see in the diagram the nail has so many pits in it. It is discrete, well-defined depressions in the nail. Yellowish or brown discoloration also occurs sometimes. And usually there is a tenderness, pain and painful nail. Tenderness and pain is present with chalk-like debris build up under the nail. You can see a kind of chalk-like substance which builds up under the nail. Another condition called as subungual hyperkeratosis is a characteristic of nail psoriasis. Subungual means beneath or below the nail. It is subungual. Hyperkeratosis is abnormal growth of thickening of skin. So subungual hyperkeratosis, it's a characteristic of nail psoriasis. Silvery white crusting under the free edge of the nail. You can see under the free edge of the nail with some thickening of the nail plate. Another sign seen in nail psoriasis is oil drop sign. It is pink or red color change in the nail surface, like oil drop just fallen on the nail. You can see in the diagram. Then another is onycholysis. That means nail gets separated from the nail bed. Lysis means destruction. Here there is destruction of the nail. Nail separates from the nail bed at the free edge. So all these are seen in nail psoriasis. Scalp psoriasis. It varies from minor scaling with erythema to thick hyperkeratotic plaques. That is minor scaling. In some cases, the scales will be minor in the scalp with redness, and in other cases, it will be hyperkeratotic, means thick, large plaques. Plaques means any elevations which is more than 1 centimeter or 2 centimeter or even larger. It is called as plaques, and it may extend beyond hairline. Since it is in the scalp, there's a tendency of scratching in the head, and this produces asymmetric plaques. Palmoplantar psoriasis, that is psoriasis that affects the palms and the plantar surface of the soles. It's superficial red plaques with thick brown scale, and it usually looks like eczema in most cases. The normal inflammation of skin, but in that case you have to check for the psoriatic manifestations in other parts of the body for diagnosing. So psoriasis have a typical features of scaling, dry scales, which shred off during on rubbing, and such manifestations has to be checked elsewhere in the body, which will helps to differentiate between eczema and palmoplantar psoriasis, and usually it is aggravated by trauma. Psoriatic arthritis is a condition which involves both psoriasis and joint inflammation or arthritis. In some psoriatic patients, as time progresses, arthritis develops as a complication, and this condition is called as psoriatic arthritis. It can be easily differentiated from rheumatoid arthritis, which is also an autoimmune disease, by the virtue that rheumatoid factor is usually negative in psoriatic arthritis, and it can occur at any age. The peak is 20 to 40 years, and incidence is equal in women and men. The major characteristics are the distal interphalangeal joint arthritis. That means the distal part of the interphalangeal joints. That means the parts of nail or the fingertip are usually affected in psoriatic arthritis. Also, dactylitis is present. Means dactylitis means inflammation of the fingers. The fingers get inflamed and swollen, and it looks like a sausage. It sometimes is called as sausage finger. The characteristics are being explained in the table. That is asymmetric arthritis. That is one or more joints are involved. Both smaller joints and bigger joints are involved, but in asymmetric pattern. Usually, it is the majority, 60 to 70% of cases are asymmetrics. That one side of the body is affected, and the joints and fingers and toes. It is dactylitis, shows dactylitis and sausage finger appearance. Then symmetric polyarthritis. Symmetric means both sides of the body are equally involved. In around 15% of the cases, symmetric polyarthritis is also seen, which clinically resembles rheumatoid arthritis. But rheumatoid arthritis is mostly symmetric, and also it can be differentiated by the factor that the rheumatoid factor will be negative in psoriatic arthritis. Also, the fingers or the parts which is affected in rheumatoid arthritis is the proximal interphalangeal joints. Here, the distal interphalangeal joints are affected more. Distal interphalangeal disease is mild, chronic, and associated with nail disease, which was explained in nail psoriasis. All those symptoms might be seen, along with pain and swelling. Then destructive polyarthritis, it's also another complication that is also called as arthritis mutilans, where there is osteolysis or destruction of small bones of the hand and feet. There will be a gross deformity, and joint displacement or subluxations will be present. Also, ankylosing spondylitis. Spondylitis is also another characteristics of the psoriatic arthritis, because ankylosing spondylitis is another condition which is autoimmune and characterized by the presence of HLA-B27, which has also is involvement in psoriasis, manifestation of psoriasis. These are the main features of psoriatic arthritis. An X-ray of the psoriatic arthritic patient. You can see the blue arrow, it's the normal joint space. You can see the red arrow, that the joint space is reduced. It's the cup and saucer effect of the fourth metatarsal bone, and the base of the fourth toe is joined to the destruction of the joint space and formation of osteolytes. The yellow circle is the pencil appearance. That means destruction. The destruction of the bone, characteristic of arthritis, mutilans, etc. We'll just go through certain features chief features of psoriasis. This is Koebner phenomenon. It is named after the dermatologist Heinrich Koebner. It's the appearance of new skin lesions on areas of cutaneous injury in otherwise healthy skin. It's also called as isomorphic response. That means in cases of in this case in psoriasis, if a skin irritation or a cut or a bruise or something occurs in a healthy part, that means in those part where there is no psoriatic lesion, in that part, if a skin irritation or a injury or a trauma occurs, you can see later this lesion similar to psoriasis arises in that area. And these lesions occur in places other than the typical areas of psoriasis. That means the scalp, the lower back, the back areas, the knees, and the extensor areas. These are the typical areas where psoriatic lesions are seen. But this isomorphic response can be seen in any other areas also where there is an injury. And it's also seen in other conditions like vitiligo, pemphigus, etc., other than psoriasis. Onset sign is another characteristic feature, that is appearance of small bleeding points after successive layers of scales have been removed from the surface of psoriatic papules or plaques. So when we see a dry scale lesion or a plaque, and if you are trying to remove it, after removing the upper plaque layer, we will see a bleeding spot in the skin. That is the Auschwitz sign. Warn-off ring. It is often the first sign that patient is responding to phototherapy. It's a treatment, exposure to light or sun. It is for phototherapy, and the first sign that lesions are healing is by the characteristic warn-off rings. That means a hypopigmented macular ring around the psoriatic lesion. So you can see in the picture a reddish psoriatic lesion is there, and around it a hypopigmented area, a blanched or pale area. Macular ring means flat and pale area around the psoriatic lesion is skin is seen. It is the first sign that the lesions are healing. Another one is candle grease sign, which is a confirmatory sign of psoriatic scales or psoriatic lesions. When the surface of the psoriatic plaque is scraped, scraping with a scalpel, the psoriatic lesion is being scraped with a scalpel. The scales will fall off. Usually, the scales falls off as layers, and we have to collect these layers, and you can see that on collection it shows coherence, or it sticks together, or is sticky in nature. It sticks together just like wax when we are scraping the wax. It's also called as a wax spot phenomenon. Then recurrence is it's a chronic relapsing cause. It occurs for years, and it subsides and relapses in between. It takes months to years interval. That means it subsides, and even after months or years it can reoccur. Now we'll come to the investigation of psoriasis. We have to collect a sufficient history and has to be evaluated. The physical examinations are to be conducted and confirmed. Those examinations which was mentioned in the previous slides, like hospital signs and candle grease signs, all these are to be conducted and the disease should be confirmed. And along with it, blood and radiographical examinations are to be done. Blood tests can be done to find out the inflammation, the ongoing inflammation in our body, like the presence of C-reactive proteins, inflammatory marker, and also to find the extent of infection going on, that is ESR. Can be conducted, and if inflammatory markers are found like C-reactive protein, we can go for a rheumatoid factor test, which would be negative if it is psoriatic arthritis. If it is positive, we can go for a rheumatoid arthritis condition as diagnosis, and if rheumatoid factor is absent, it is psoriatic arthritis. C-reactive protein will be increased in or present in both conditions. And then we can go for an X-ray. X-ray can be taken to find out the lesions in psoriatic arthritis, like arthritis nucleus or destructions of bony parts or joints or decreasing joint spaces, etc. Skin biopsy is considered as an important investigation method. Usually a skin biopsy is done to find out hyperkeratosis or the increased thickness of stratum corneum. There will be increase in the skin cells, keratocytes. The stratum corneum is increased in size. It's a layer of epidermis, and it can be found out by a skin biopsy. In parakeratosis means the presence of nucleated cells in the stratum corneum. Usually when these proliferated cells or the increased number of keratocytes, if when they reach the stratum corneum or the upper layer from the basal layer, it loses its nucleus in normal cases. But in case of psoriasis, the nucleus is retained in the cells. So if that nucleated cell is found in stratum corneum, this condition called as parakeratosis, psoriasis, type of psoriasis. So skin biopsy is important for that. Another one is Monroe's microabscess. Means collection of neutrophils from stratum corneum. So we can get the collection of neutrophils, which indicates an infection is going on. These neutrophils appear by infiltration from the dermis. It's a part of an active immune system going on. And this is a cardinal sign in test in psoriasis. Monroe's microabscess is a collection of neutrophils in the stratum corneum of epidermis. All this can be found out by skin biopsy.